Ah, my wizarding friend. I have often thought of you as the rock and roll wizard of us all.
Yeah, well, when you have a lot of magic mushrooms to share with the world, you kind of go in with that crowd. It's just kind of what happens, dude.
Oh, I like that kind of magic. Oh, it is fantastic. But do you remember that time that we were at Coachella with our wizarding friend, Dr. Bright?
Yeah, he got a really bad case of the norovirus. I remember that clearly.
Yes, and he was bleeding from his rectum for days upon days, and we just happened to have the HemaQ test. We happened to have this, and we tested this fellow's blood in the midst of all of this blood from his rectum.
Yeah, it was one of the best DREs I've ever done.
Oh, you have talent in game, my friend. Talent in game. And then you so astutely diagnosed the GI bleed, and we found his hemoglobin. Hemoglobin to be 8. It was 8, and he said, I need blood, boys. I need blood. Yet he was stable. And you denied him. Why did you deny?
I mean, I told him that blood ain't going to do him no good. First off, we don't even have blood. We'd have to kill one of the muggles, and I'm not into that kind of stuff.
No, we don't do this. Yes. What was the magic number he sought?
Well, he just wanted it, but I told him, no. You got to be like less than 7. Or if you're really sick and it happened fast, then maybe 9. But you're at 8 and you're doing fine. So just chill.
Oh, you are a true wizard, despite your other proclivities. Off to you, Dr. Morrison.
All right, boys. Well, I don't know whether you're Merlin or ZZ Top, but either way, it's absolutely ridiculous. I love it. So, of course, as you both have astutely pointed out, we are talking about acute lower GI bleed. I love this topic. This is a good one. All right, this New England Journal paper did a review on the management of brisk, large volume lower GI bleeds. We know these patients can actually be pretty sick. We see it most commonly from diverticulosis. Up to 65% of cases of GI bleed can happen from that. Ischemic colitis is the close second contender, as are hemorrhoids. And thankfully, neoplasm and angiectasias are far less common. All right, so how do these patients clinically present? We know that hematochezia is the textbook answer, right? They'll present with bright red blood per rectum or even maroon, even melanotic stools sometimes. However, you should also remember that a brisk upper GI bleed can sometimes also present with hematochezia, and that's a tricky one. That's a common pitfall. So patients bleeding so much from the top that it's just traveling all the way down, and so beware of that. But for the most part, most straightforward lower GI bleeds will be hematochezia. So initially, what do? Just like any other unstable patient, this is the ABC patient, right?
Direct pressure.
Direct pressure. Yeah, exactly. Well, no, not so much. You're going to make sure their vitals are okay. You're going to start an IV. You're going to, put them on the monitor. You're going to do a digital rectal exam, just as you astutely did there, ZZ Top or Merlin. I forget which one you are. And what are we looking for? You're looking for the color of that bleeding of the bloody stool. You're going to be asking about the frequency of bowel movements, how much. That's always hard for patients to quantify, but asking if it fills the bowl or if it's just a couple drops. The duration, how long has this been going on? Any other associated symptoms? Often these patients will be lightheaded, fatigued, etc. And then any medications that they're on, right? And we're all, we have so many patients these days on anticoagulants. So certainly finding out what meds they're on is important. And what labs do we want? I mean, all of them, right? We want CBC, we want electrolytes, we want to know their coags. You're going to order a type-in screen. And one sort of pro tip is that if they have a very elevated BUN, that should actually usually be a tip-off for upper GI bleed. Not that it can't happen with lower GI bleed as well, but elevated BUN is typically common in upper. What are the risk factors associated with poor outcomes? So if your patient is already hypotensive, you're behind the 8 ball. If they're tachycardic, right, they're trying to compensate for that. Now, the one caveat I will say to that is if you have a patient on a beta blocker, they may not be tachycardic and they can still be sick. So don't let that fool you. Patients having ongoing hematochezia, that's a problem. If they're elder, so older than 60, and if they have some creatinine elevation as well, it's a problem. And obviously, if the patient has any significant coexisting conditions, we say this a lot with our hepatic patients and any other patient on anticoagulants. All right, so how should we be managing these patients? We already talked about the fact that these are ABC type patients, right? But as you both alluded to so astutely, what is that magic number? And I feel like the conversation of how much blood should a patient have, what should their hemoglobin be, is a conversation we have a lot with GI. And I feel like it's a little bit of Goldilocks and the Three Little Bears. Like, you don't want too much, you don't want too little, and what is just right? And this review article states that 7 is that magic number. And in the otherwise healthy patient with no other coexisting conditions, if they're otherwise hemodynamically stable, then 7 should be our goal number. So what's the number?
7.
7.
Matthew, I can see through the magic binoculars that Dr.
That's right.
Bright's anus is still bleeding. But I
That's
can
right.
also see that his hemoglobin is 5. It is 5. What
Yep.
to do? What shall we do?
All right. We'll transfuse him. But let's, not at Coachella. Like,
Not
just ruining the vibe, man.
Coachella or not, he must receive blood.
That's right. So you want to get the average healthy patient to 7. Now, if they do have underlying comorbid diseases or they're having, concomitant recurrent bleeding, then you can bring them up to 9, especially if they're going to have a delayed intervention. All right. So what is the treatment of choice? It's colonoscopy, and that should be done within the first 24 hours after you've resuscitated them and after they've had a nice, good, adequate colon cleanse. That's got to be terrible, by the way.
That's harsh, man. It's like,
That's
dude, you're bleeding out of your ass and you're hemodynamically unstable. Can you
Yep.
just drink this big bottle?
It is a mystical cleanse. You too know not.
Now, sometimes upper endoscopy is indicated if you think the patient has both either upper GI bleed or upper and lower GI bleed. And if they're hemodynamically unstable, then they'll scope them from both ends, top and bottom.
Yeah.
All right. Is imaging or procedural imaging ever an option? And the answer is yes.
Yes, it is.
CT angiography is actually much better than scintigraphy.
Scintigraphy. Did you not take... Where was she in the first year of wizarding school? And we know the pronunciation of unpronounceable words. It is the unforgivable curse of scintigraphy.
And who should we be getting imaging on? It's in those patients with brisk bleeding if they continue to be hemodynamically unstable despite resuscitating them, and when colonoscopy is not diagnostic or when it's actually unsuccessful. So if you get a CT angio and it's positive, then you're going to want to follow that up with a procedural angiography. All right, let's talk about treatment. We're going to go with the endoscopic option, oftentimes, where they will actually use injected dilute epinephrine right into that bleeder.
Dilute.
Or they may mechanically stop the bleeding or cauterize it, right? Contact thermal therapy. And we don't have to get into the specifics here, but just know that those 3 options are common. And then, of course, in addition to what we do, which is that supportive medical care, also you will involve your surgical colleagues if you think this is something due to ischemic colitis or some type of inflammatory and ulcerative colitis, or unfortunately a neoplasm. All right, angiography with transcatheter embolization. Fancy. But yes, this is indicated for those patients who have ongoing bleeding despite that endoscopic or radiographic treatment. And so this is an important option to know about. Antiplatelet agents. So who should be starting or stopping their aspirin? Well, if you are taking aspirin for primary prophylaxis, you've never had an MI before, but you're taking sort of an aspirin a day to keep your MI away, those patients...
As a protective spell.
That's right.
Yes.
In those patients, you should stop your aspirin. But if you are someone who's already had a heart attack, you're taking aspirin for secondary prophylaxis, and you have an acute lower GI bleed, you should not discontinue that aspirin. That's a really important point. And what about a second antiplatelet agent? It's okay if they've been stented within the last 30 days and they've had ACS within the last 90 days, then they should continue with that second antiplatelet agent as well. So in summary, resuscitating a patient to a hemoglobin level of 7 is important for the otherwise healthy patient, and 9 if they have other comorbid diseases, or it's going to be a significant delay in timing for their colonoscopy. All patients ideally should undergo colonoscopy within the first 24 hours. Of course, that's after you've sort of hemodynamically resuscitated them. You should be getting radiographic imaging, CT angio we talked about, if the bleeding is brisk and if it continues and they're unstable despite your resuscitation. And all of those positive images should be followed by angiography. And lastly, do not discontinue the aspirin if it's being used for secondary prophylaxis. All right, Merlin and ZZ Top, it's been a pleasure.
Oh, were we supposed to record that?